moving on, when talking about some of these ventilator settings for somebody in Ards, there are some protocolized tables that you can look at that can guide your therapy and let you know sort of how to balance PEEP and FiO2. Once again, when talking about Ards, we're really shooting for hypoxemia treatments and things to help the hypoxemia. The FiO2 here and the PEEP here can be guided by tables. The ArdsNet was a consortium of multiple medical centers, and the ArdsNet or ARDSNet, you can go to their website and find some of the PEEP and FiO2 tables. There are two tables there. There is a high PEEP strategy and lower FiO2. There's also a lower PEEP and higher FiO2 strategy. So between the two, you can take a look. Sometimes we can get away with a little bit lower PEEPs if we can, because we're starting to see in some of the COVID patients that some of their lungs are compliant. So maybe starting with a low PEEP table is something that might be able to help. But that's at least Ards net protocols that you can see. And if somebody needs more PEEP, you could be guided by the high PEEP strategy as well. So that's sort of how you balance out where if you start getting up to PEEP of 14 or FiO2 of 50%, where do you go next? Those tables can help you, as you can see. Last but not least, we talked earlier about peak inspiratory pressure and plateau pressure. When somebody's on volume control mode, then when you control for the volume, the variable becomes that peak airway pressure. Once again, just graphically speaking, and I don't want to overwhelm with graphics, but if we talk about airway pressure versus time, right? This is a PEEP of 12 currently. So if these are increments of 5 in centimeters of water pressure, 10, 15, 20, then the lowest pressure the patient will basically be at, even at end exhalation, will be this 12 right here. And so everything will start from there and then come back, and you won't get below that pressure. So you can see as the pressure is lifted because of that positive index pressure, our peak inspiratory pressure can be a little bit high. Now, once we start to get above 30 on the peak inspiratory pressure, we really need to check out about what the plateau pressure is. And we would do an inspiratory hold, stop flow for a second, and see what is this plateau pressure. And a respiratory therapist can do that for you. If your peak pressure alarm is going off at above 30, it's time to take a look at a plateau pressure. And overall, our goal in Ards is a plateau pressure of less than 30. And we can get there by dialing down the tidal volume, but even as low to 5 cc's per kg of ideal body weight. So this is per kg of ideal body weight. And we can go down to even 5, and we can even go down to 4 based on studies we've seen before to be able to get to that plateau pressure of less than 30. As we rob Peter to pay Paul, we're going to drop the tidal volume. You can imagine what that will do to your minute ventilation. That will decrease it, maybe even something like 3 or 4 liters per minute. And that's where the carbon dioxide level may increase, and we're okay with that as long as the pH perhaps is above 7.2. We call that principle permissive hypercapnia. So in Ards patients, usually the hypercapnia is not what is lethal for the patient, it's the hypoxemia. So we allow a little bit of acidemia, we allow that little bit of carbon dioxide to be high, and the higher the carbon dioxide load they have, then a little bit more acid is around the body and the pH drops. When that happens, we're okay to the tune of about 7.2. Then we don't get too concerned about it. So we can drop these things and go down, maybe here for a 70 kilogram person, we go down to 350. And then this wave is able to come down and get our plateau pressure less than 30. If it remains high, we could come down to even 280. Or a 70 kilogram person times 4 cc's of ideal body weight here, and come up with 280. We're just going to be, watching the pH. Unless it is staying above 7.2, we're pretty happy. And so now we're really focusing on the PEEP and the FiO2, and then we base everything on blood gases. If the oxygenation is good and our PaO2 is above 60, we can take this percentage and keep climbing this down, and then climbing down on the PEEP, basically on those ArdsNet tables that help you on high or low PEEP.